Hello. Tonight we are going to speak about overdrainage in shunted patients, how it is diagnosed and how it should be managed. First, you know that this is a growing problem in both sense of the term, because it is a growth which causes elevation of stature, which causes stiffening of the ventricles, because the stature means pressure. And also because pressure-regulated valves are becoming prevalent over the market because flow-regulated valves are progressively withdrawn. So there are many unknowns in the pathophysiology of the overdrainage, and we need to understand it in order to cure it. So what do we know about the hydrodynamics of the shunted brain, and how does it present according to the different types of valves? First, the clinical presentation, it can be very acute in the postoperative period with the appearance of an epidural hematoma or a subdural hematoma or a collapsed calvaria like the baby in the middle. But it can be also less acute with a collapsed calvaria. This is a baby with a very big macrocrania, and we considered putting a low flow valve, but in fact he had a standard valve, and this is the result. He has a collapsed calvaria. This is very problematic. We don't have many solutions for that, but hopefully it was not a subdural, which would have been more complicated to treat and require reoperation. And finally, he grew not so badly with a very deformed calvaria, very brachycephalic. But finally, he found himself the solution by letting the hair grow. Then it can be subacute, like in this patient who had a post-tumoral hydrocephalus, and she needed a plexectomy because of complicated history. And then we put a standard OSV2 valve with a flow of 18 to 30 milliliters per hour, which cause subdural collection. So we change her valve for a low flow NPH valve, which flow is 10 milliliters per hour. This is the curve of this valve, which shows a plateau around 10 milliliters per hour. And it was okay. And we are very grateful to this type of valve, but unfortunately, it has been phased out by the industry because it was not profitable. Then in the chronic overdrainage, how do we interpret the headache in the patient? It can be both a feeling of compression. It is more often accompanied by vomiting in case of raised ICP, but it can also occur in overdrainage. Then it both occur in the morning, but the raised ICP wakes the patient up, while in overdrainage the patient has headache when he stands up. So it may be possible to make the difference, and also both of them can cause diplopia, and very characteristically the overdrainage causes headache in the upright position. So this is mostly the position which helps us to determine if there is overdrainage. However, in the raised ICP, we have also headaches caused by change of position. So it may be quite complicated to make the difference between both. And also in these patients, can have many causes of headaches. They can have migraine, like any one of us. They can have ophthalmological headache because of diplopia or something else. Painkiller abuse is very frequent, and scar pain can also occur in these patients when they are growing and the valve pulls on their nape. Then we do imaging, and especially MRI, which can show us very thickened calvaria, like here, deformed brainstem, like in the middle, and dural uptake. However, it may be difficult to convince the radiologist to inject some gadolinium. And also we can have very specific spinal imaging with the dural thickening and compression of the spinal cord, causing very specific shunt myelitis, which happens most often in post-meningitis hydrocephalus. And CT scan can also be very useful in emergency to show the collapsed CSF space and also to show some synostosis and calcifications, like in this case with synostosis and the typical armored brain. Then we can have tonsillar herniation, which happens after lumbar drainage, especially lumbar peritoneal drainage because of the pressure gradients. It's easy to understand, but it happens also after ventricular drainage and can be associated with craniosynostosis or not. But it attests of the loss of CSF pulsatility, and it may require some treatment. Sometimes it is associated with a syringomyelia, so we have to determine whether there is a hyperdrainage with a Chiari causing compression of the craniocervical junction, or if there is hypodrainage causing the accumulation of CSF in the spinal cord. Then we have the stiff brain, because these patients have a loss of pulsatility of the CSF, so they lose the habit of contracting and expanding. And these small ventricles tend to block the shunt. This is a teenager boy who arrives in emergency because of a loss of vision. He declares no headache. However, when we found his baseline CT scan, we show that the ventricles were slit-like, and in fact he had a shunt obstruction, and with only a slight enlargement of the ventricular size. So these brains are very stiff. They have a very low compliance, and the small increase in volume translates of very high pressures in some cases. And it can also cause a cycle of recurrent shunt obstruction, like in this patient on the right, where he came with headache. He had a CT scan, but this headache improved, and the MRI showed slit ventricles again. He was spontaneously relieved until a few days later he came again for the same symptoms with ventricular enlargement, and at that time he underwent a shunt revision. So it can induce a cycle of overdrainage, causing ventricular collapse, causing obstruction of the catheter, causing ventricular dilatation, then the release of obstruction, and then again overdrainage. So it can happen for some times. So do we need ICP monitoring? When and why do we need it? We needed it when we consider calvarial expansion, and we have to remember that it can be falsely negative and had to be repeated when the headaches are present. And so we have to take into account this false negative. And also we have to think about the differential diagnosis with hypopressure, like in this patient below. He had small ventricles, and his intracranial pressure was negative, in fact. So we have to examine the patient and measure his head circumference and see if there is a progressive microcrania, like illustrated in the chart below. And sometimes we can see a progressive closure of all the sutures, like in this patient above who had many CT scans. We do less nowadays, but it is very illustrative. And it happens mostly with pressure-regulated valves. We have to look for papilledema and do ICP monitoring if we consider decompressive surgery. So this is a series, in my experience in Lille. We reviewed the charts of 1,629 patients, and among these, 22 required decompressive craniotomy, which is 1.35 patients, about 10 years old, and almost all of them had pressure-regulated valves. And the presentation was intracranial hypertension in 20, which was severe, in 12 with vision loss and so on. But only 11 of the 26 had progressive microcrania. And also another feature which was important is that they require repeated shunt revision probably because of the vicious cycle exposed below. So the mean was 4.1 reoperations before craniotomy. The predisposing factors were to be male, have absolutely no clue why it is so. And the um, the type of valve was not significantly different. And what was very significant was the young age at the first shunt and the post-hemorrhagic hydrocephalus, and also the number of shunt revisions. But as I said, it was as well a cause or a consequence of the overdrainage. So what do we what did we do? We did a large frontotemporal cranioplasty with expansion and reconstruction with overlap of the frontal bone flap on the orbital bundle in order to improve the not to damage the morphological outlook, of course. And also we had to revise the shunt and put, whenever possible, a flow regulated valve. And this is the result of the cranial expansion in this patient. So sometimes we go from pressure regulated to flow regulated valve, and it is for the patient a change of paradigm. And in this patient, we had initially a baseline CT with slit ventricles with a Meadows valve, and in emergency he went to another center where he had a shunt revision with implantation of an OSV2 valve, and this is his new baseline imaging, which shows much more normal ventricular size. And also some of these patients are changed from valve to ETV, and it is really a marked difference for them. This is a child who had post-hemorrhagic hydrocephalus. He was shunted, and this was considered his baseline imaging. And sometimes later, he presented with peritonitis caused by ruptured Meckel's diverticulum. So he had a laparotomy in emergency. So he was in external drainage, and we choose to do an ETV, which was very successful. And after this ETV, he was feeling better than ever because he had a much more physiological treatment for his hydrocephalus. Then are the adjustable anti-siphon valve a solution? This is a question of a balance of pressure. If we consider that the pressure of opening, that is the zero of the valve, is the pressure of the valve plus the pressure of the anti-siphon plus the intraperitoneal pressure minus the siphon effect minus the intracranial pressure. And this is the sum of all these factors which amounts to the opening pressure, which is the zero of the valve. But that means that the intracranial pressure is equal to the pressure, the opening pressure of the valve, plus the anti-siphon, plus the abdominal pressure, minus the siphon effect. So these values are what we found generally, and we can make the total for the vertical position, which is 10 plus 40 anti-siphon pressure, plus 5, which is abdominal pressure, minus 60, which corresponds to 60 centimeters between the head and the abdomen as mean. So it is mildly negative. And if we compare with the lying position, we have 10 plus 0, no anti-siphon, plus 5 abdominal pressure, minus 0 anti-siphon is 15. So we have a range of pressure between minus 5 and plus 15. And we have to ask, is it the physiological range? And one problem with this valves is that when patients present with headache, when in the upright position, it's difficult to guess if it is a over drainage or under drainage. So we have to look at to wonder if the maintaining of a low intracranial pressure is a neurosurgical goal. Historically, in the 50s, were developed the first pressure-regulated valves, which were improved in the 90s by being adjustable, and in the early 2000 years by an anti-siphon device. But at the end of the 80s had appeared flow-regulated valves, which were designed to mimic the ICP physiology and the CSF physiology with a constant flow of CSF, allowing the pressure to vary with time. Unfortunately, this valve is in the process of being phased out, again, because it is not profitable. So it shows a history of wrong, it joins a long history of wrong technological choices. Remember the Remington type machine, which with the AZERTY or QWERTY keyboard, which was created in 1874. In fact, the keyboard was designed to slow down the typing in order to avoid jamming of the key. So we don't have keys anymore, but we still have this keyboard, which is designed to slow down the typing. Another striking example is the reconstruction of the electricity grid after World War II in Europe with 220 volts, because it allowed to carry twice as much energy for the same with the same cable. But because of the high voltage, people continue to die of electrocution every year. So in conclusion, the diagnosis of overdrainage is mostly made on signs and symptoms. We have to interrogate thoroughly the patient. It can be misleading with hypodrainage, and it causes serious complications with recurrent blockade, craniocerebral disproportion, and spinal stenosis, and also blindness. It can also create Chiari, syringomyelia, shunt myelitis, and it is an unresolved technological challenge. I thank you for your attention.